mobility of the lumbar spine. So if we take lumbar spine here, posterior, this is our cervical spine, thoracic spine, lumbar spine, and sacral spine. So this is our lumbar spine. Here movements of the lumbar spine. First one, flexion extension will happen in the sagittal plane and frontal axis. Sagittal plane, frontal axis, and lateral flexion will happen in the frontal plane and sagittal axis, and rotation will happen in the transverse plane and sagittal axis. So if we come to lumbar spine, L1, L2, L3, L4, L5, total 5 vertebrae will be there. In these 5 vertebrae, see, from L1 to L4, the flexion extension movements will happen, okay, and lateral flexion and rotation movements will happen very slight, okay, very mild ROM will happen in the L1 to L4 lumbar vertebra. And at the same time, if the person is in neutral position, so if in this neutral position means the lumbar spine will be neutral. If patient is doing lateral flexion and rotation in the lumbar spine, movements will happen. Suppose if the patient is in lumbar spine flexion, then the lateral flexion and rotation will not happen. Okay, this one point. So here lateral flexion rotation will happen when the patient is in neutral position. If the patient already in lumbar spine flexion, then lateral flexion rotation will not happen. Because of the here lateral flexion and rotation movements are very less because of the facet orientation, facet joint orientation, means zygofacial facet joints orientation. And one more thing, posterior longitudinal ligament and posterior annulus fibrosus. It is IVD, intervertebral disc. So because of these structures, the lateral flexion and rotation movements will be limited in the L1 to L4. Limited in the lumbar spine. Okay, the person is in flexion. If the person is in lumbar spine flexion, here lateral flexion rotation is not possible because of the posterior longitudinal ligament and posterior annulus fibrosus. So when the person is in flexion position, that time this posterior longitudinal ligament at the same time posterior annulus fibrosus of the IVD is not going to allow for the lateral flexion and rotation. Suppose if the patient is in neutral or maybe flexion of the lumbar spine, the facet joints will not allow rotation, in any position, either neutral position or flexion position or extension position, whatever the position of the lumbar spine, the facet joints are not going to allow the lumbar spine for the rotation. If you see next point, facet joint orientation, the orientation of the facet joint. Here facet joint orientation, how it will be backward, upward and medially, and it is going to make a 90-degree angle in the sagittal plane. So this is the orientation of the facets. So here these facets are going to allow lumbar spine for flexion and extension movements. Suppose if we see flexion is less compared to extension. What it means? Flexion RVM will be less. That means it is going to restricted more compared to the extension movement of the lumbar spine. And at the same time, see here, it is very, suppose if we take this our lumbar spine, this is our sacrum, this is our thoracic spine, this is our cervical spine. If you see here, the curvature is anterior and posterior. Okay, so anteriorly the lumbar spine is convex, anteriorly convex, posteriorly it is concave, and whatever you do flexion, either maximum flexion of the lumbar spine, it is very difficult to make the lumbar spine from lordotic. This is lordotic. Lordotic means anterior convexity, posterior concavity. Whatever the movement you do, forceful or maximum flexion, we can't able to make this lumbar spine from lordotic curvature to kyphotic. What it means? So see here, this is thoracic spine. If we do flexion in the lumbar spine, lumbar spine can go for flexion, but it can't come to like a kyphotic curve. So lumbar spine can't become like a kyphotic curve with our flexion movement. Okay. Next point, if we take the amount of flexion will happen most commonly. If we take RVM of flexion, most of the RVM will happen between, here sacrum will be there, no, L5 and S1. So it will happen between the L5 and S1 vertebrae. Lumbar flexion, most of the RVM will happen between the L5 and S1. Little bit flexion will happen between the L2, L3 and L4. So this is one point about flexion. If we see overall RVM, either flexion and extension, most of the flexion will happen at the L5 and S1. This is the first place, flexion extension. Okay, then second place L5 and L4, third place L4 and L3, next L3 and L2, of that L2 and L1. So this is the second place, third place, fourth place and fifth place. So major RVM will happen at the L5, S1. So like the same, it will be like that. So this is first place where the maximum will happen, this is second place where maximum will happen, third place, fourth place and fifth place. So these are the regions where the RVM, flexion extension, will happen in the lumbar spine. So as next point, if we take lateral flexion and rotation, these movements will happen at the upper lumbar region, L1 to L4, and then this is lower lumbar region, L5. Here will be having sacrum. So if we take lateral flexion and rotation, this lateral flexion and rotation will happen more at the upper lumbar region, that is L1 to L4. So where is the exact site for the lateral flexion rotation? Most of the where it will happen means in the lumbar spine. Most of the lateral flexion and rotation will happen between the L2 and L3. So this is the exact site where lateral flexion and rotation movement will happen more. Okay, this is one point. Here one special point is there. If we do flexion of the lumbar spine, it is going to, if we are doing flexion of the lumbar spine, it is going to happen in a two order ways. First one, lumbar spine will involve. After that pelvis will involve. Why pelvis will involve means here L5 is articulating with the sacrum is going to articulate with the here. See here what will be there, SI joint, sacroiliac joint. This is one hip bone. Imagine this one hip bone. Here also will be having one more hip bone. So here we'll be having hip joint. Here also will be having hip joint. So here the maximum amount of flexion will happen between the flexion extension lumbar spine L5 and S1. So here if it is moving L5 vertebra, automatically it will articulate with the sacrum. Sacrum also will move. So here when we are doing maximum flexion, that time it is going to take two series. First one, lumbar spine will go for flexion. After that pelvic will move. What are the movements of the pelvis? We know anterior pelvic tilt, posterior pelvic tilt, lateral pelvic tilt. In this lateral pelvic tilt will be having pelvic hiking and pelvic dropping, and one more pelvic rotation. So these are the four movements. Okay, 1, 2, 3 and 4 movements. Anterior pelvic tilt, posterior pelvic tilt, lateral pelvic tilt. In this pelvic hiking and pelvic dropping. Fourth one, pelvic rotation. In this rotation also will be having two different rotations. Okay, forward rotation and backward rotation. So these are the movements of the pelvis. So how the lumbar spine is going to take the help from the pelvis to create full RM, or maximum flexion of the lumbar spine. This is nothing but the lumbar pelvic rhythm. This is also called as lumbopelvic rhythm. So this we'll see in the next part. Okay.